My name is Ian Beck. I'm president of the Graham Beck Foundation, which is a private family foundation based in Montreal that's working across the country to transform mental health services, particularly with respect to integrated youth services. Bonjour et bienvenue à tout le monde. À ce webinaire au sujet des ressources humaines dans les services de santé mentale. Je suis Ian Beck, président de la fondation Graham Beck, une fondation basée à Montréal qui travaille avec beaucoup de partenaires partout au Canada pour aider à créer des bons services de santé mentale, surtout pour les services intégrés pour les jeunes. Now, we're focusing on health human resources today because, in our view, as governments work to improve our mental health services and address what has been a growing demand for service, health human resources will be key to be able to do this successfully. Not only to create the capacity to serve people and to get the outcomes that we want, but also to address longstanding issues of equity in mental health services. We are very pleased today to have Dr. Paul Arnold to moderate this webinar. Thank you, Paul. Paul hails from Calgary, where he is a practicing psychiatrist and a researcher who is affiliated with the Alberta Children's Hospital and the University of Calgary. So thank you again for joining us, and I want to particularly thank our speakers for generously donating their time, some of whom it's rather late in the evening. And I hope you enjoy the webinar. Paul, over to you.
Thank you so much, Ian, and thank you to the Graham Beck Foundation for bringing us all together, as always. And thank you to the audience for joining us today. Before we begin our webinar, I'd like to begin with a land acknowledgement. So although we are meeting today on a virtual platform, we acknowledge the Indigenous peoples of all the lands that we are on today, from coast to coast to coast, in a spirit of reconciliation and collaboration. We recognize and acknowledge the relationship that the First Nations, Inuit, and Métis across Canada have with the land all Canadians live on and enjoy. And we do this to reaffirm our commitment and our responsibility in improving relationships between nations and improving our own understanding of local Indigenous peoples, their cultures, and I would say in the context of this talk today, in terms of the issues that they also face in terms of mental health. From coast to coast to coast, we acknowledge the ancestral territory of all the Inuit, Métis, and First Nations people that call this land home. So I'm about to introduce our speakers, and it gives me great pleasure to do so. But before introducing our speakers, just a few housekeeping notes. So the webinar will be recorded, and a recording will be shared with the audience afterwards. And just want to remind folks to keep yourselves on mute when you're not speaking. So this is a WebEx meeting. So it's so, as you know, just from our experience with WebEx and similar platforms, just important to keep yourselves on mute to keep that background noise away. And there will be time for Q&A following the presentations, and participants are welcome to include questions in the chat. Again, because it's such a big meeting, we'll kind of moderate questions through the chat as opposed to being able to speak directly. But I look forward to that, and we have allowed ample time at the end for Q&A. The topic of today, as mentioned by Ian, is innovation in mental health human resources. This, of course, is an extremely important, critical topic, as reflected with, I think, the enthusiastic response and the attendance today. And I think what you're going to be hearing throughout the talks is really that in order to meet the vast needs we have And as Ian was saying, in terms of speaking to our funders, to government, the needs in mental health care are going to require a really innovative approach. So it's not just about increasing the numbers. Of course, we need more people working in the mental health workplace, but ensuring that our interventions are appropriately timed, ensuring that the providers are appropriately trained so that it's not just getting access to care, but getting access to the right care and to evidence-based interventions. And I think as part of that, just really thinking about outside the box, as you'll hear in some of our talks today about new providers, maybe people we hadn't thought about previously in terms of providing mental health care. You're going to be hearing about peer support, for example, and all the and sort of the innovative work that's being done there. So it gives me great pleasure to introduce our speakers and also to note that the webinar does feature experts from the UK and Canada who will explore innovative ideas and impactful solutions for addressing these workplace challenges. So without further ado, what I'm going to do is I'm going to introduce all the speakers at once, just because the talks are relatively brief. So I think it will be easier just to hear about the speakers at once, and you'll hear about their impactful work. So to begin with, we'll be hearing from Dr. Clark. So Dr. David Clark is the Emeritus Professor of Experimental Psychology at Oxford University. He is an architect of the English Improving Access to Psychological Therapies, otherwise known as IAPT program, which will be known to many of you. Dr. Clark will speak to the impact of training thousands of new therapists and practitioners in the delivery of evidence-based services and how he is focused on disseminating effective psychological treatments within the English, but also in multiple international healthcare systems. Dr. Clark is also well known for his pioneering work on understanding and psychological treatment of a wide range of anxiety disorders, including panic, social anxiety, health anxiety, and PTSD. And he has received numerous awards, too many to list here, but they include Distinguished Scientist and Lifetime Achievement Awards from the British, Canadian, Dutch, and American Psychological Associations. Next, you'll be hearing from Dr. Peter Fonagy, so our second speaker from the UK. Dr. Fonagy is Director of the Division of Psychology and Language Sciences and Chief Executive of the Anna Freud Center for Children and Families. Particularly important to the context here, he's the National Clinical Advisor to the National Health Service, or NHS, in England on children and young people's mental health policy. His clinical and research interests lie in early attachment relationships, social cognition, borderline personality disorder, and violence. And the central focus has been an innovative research-based psychodynamic therapeutic approach called mentalization-based treatment. And that was developed in collaboration with a number of clinical sites, not only in the UK, but also the USA. And similar to Dr. Clark, he has received too many awards to mention, but also has received Distinguished Scientist and Lifetime Achievement Awards from multiple national and international professional associations, and he's an honorary fellow of the American College of Psychiatrists. And he's going to be sharing his insights about child mental health research in particular as it pertains to this topic. And then you will hear from our Canadian speakers. First, you'll be hearing from April Furlong. So April began her career as an occupational therapist and has since worked for almost 25 years in the mental health, substance use, and addiction sectors. And she's managed a broad range of research, program development, system planning, performance measurement, and evaluation projects at multiple levels, national, regional, provincial, and agency levels in jurisdictions all across Canada. And she's going to be highlighting findings again, relevant to this topic on from a recent scoping review of training innovations, strategies, and models, focused on developing, preparing, and integrating new provider roles. Alison Dunning will be our last speaker. And Alison also hails from Canada. She's the National Manager of Peer Support Canada. And Alison draws upon her lived experience of mental health challenges while building, implementing, and evaluating peer support programs in community, private, hospital, and post-secondary education settings. Alison's going to speak about these personal lived and living experiences and while also encouraging attendees to ensure that we're considering the past, present, and future of the field, and with a particular emphasis on integrating peer support workers in frontline positions. So without further ado, I will turn things over to our first speaker, Dr. Clark.
Thank you. So it's a great pleasure to be joining you this evening, and I'm going to be talking about the way that we train clinicians to participate in the English Talking Therapies program for adult anxiety and depression. Next slide. So what is what we call the NHS Talking Therapies for Anxiety and Depression, previously known as IAPT, or Improving Access to Psychological Therapies? Well, it's a public promise that everyone who receives treatment in this new service will get a evidence-based psychological treatment appropriate for their clinical condition and recommended by our impartial body, the National Institute for Care and Clinical Excellence. That therapy will be delivered by clinicians who are fully competent to deliver that therapy. They will also benefit from weekly clinical supervision, and that the outcomes of every single patient that they treat will be recorded using patient-reported outcome measures, and that at the level of each service, we will publicly report the data. So we will report how many people recover, how many people improve in each of the services. Thank you. Next slide. So in order to create this program, we needed to create a large workforce. It's currently nearly 11,000 clinicians now. The program operates on step care principles to make treatment delivery as cost-effective as possible. So for those people with more mild to moderate anxiety and depression, the first treatment they will often get is what we call a low-intensity intervention, such as guided self-help, computerized CBT. And many people respond well to that. But if they don't fully recover, the idea is they're then stepped up to more conventional once a week, face-to-face, by video or in-person therapy sessions. And the people who have the more severe problems would go straight to the high-intensity intervention. In order to deliver that step care model, we have created two different types of clinician. A new workforce that we call the psychological well-being practitioners, or PWPs, and they deliver the low-intensity interventions, and then what we call the high-intensity therapists. The PWPs are people without a lot of extensive experience of mental health before they join the program. They're mainly recent graduates in psychology. The high-intensity therapists, though, are drawn from a wide range of different mental health related professions. It might be clinical psychology, occupational therapy, social work, mental health nursing. So they've all got some mental health experience. Both workforces are trained for 1 year in a combined university and in-service training program. This is very important. So they will go either 1 or 2 days a week in their service, in the university with clinical workshops and things, but the rest of the week they will be working in a talking therapy service, seeing patients who have exactly the problems that they've been trained to treat. So we guarantee that from the start, everyone gets to meet people with exactly the problems that they've been trained to treat, and that occurs in parallel with the university training throughout the year. It's a large program, so we rely on many universities to deliver the training, but they all deliver the same national training curricula. The curricula were designed in order to ensure that people are trained in the particular skills that are necessary to deliver our relevant evidence-based treatments, whether they be cognitive behavior therapy, interpersonal therapy, brief psychodynamic therapy, mindfulness-based cognitive therapy. And you can see the training curricula for the published on the web link you can see here, which I think will be distributed after the talk. In order to pass your training course, you need to meet criteria which are the same in all of the universities. but they involve, as well as various academic tests and things, demonstrating that you have the relevant clinical skills in videotapes of actual client sessions and standardized role plays. This program, which is much more rigorous than we used previously, does seem to have created a workforce that gets excellent outcomes, as you'll see in a moment. But we have noticed that it has a weakness, and that is that the psychological well-being practitioners, who are paid on average less, they're paid essentially the English national wage, are also very ambitious people, and they'd like to learn how to become high-intensity therapists who are paid more, about 1.5 times the national wage. And so many of them move on in our program, which, as it's expanding, that's possible. So we now have a very large number of people who are trained as both PWPs and high-intensity therapists. And at the moment, we say, well, if you become a high-intensity therapist, forget about the low-intensity skills you've acquired, because you're no longer doing the low-intensity work. We're beginning to think this is silly, and so we're experimenting with essentially doing all of the step care treatment from a single therapist who has both types of training. And we're beginning to find this very efficient, because it means often you might do the low intensity work for a number of sessions. If it doesn't get you all the way you might do a few sessions of high intensity work to unblock something and then carry on with the low intensity work. So this is an evolving model. Next slide, please. So what has the program achieved? Well, these sort of graphs give you a rough idea. So it started small in 2008. We treated 93,000 people. We now see about 1 million people every year for an assessment. Of course, not everyone has anxiety and depression, but for those people who do, we offer them a course of treatment. And so we treat around about 670,000 people every year. They don't wait long, about 20 days to start treatment. We are able to get outcome measures on 99% of that 670,000 people, mainly by giving them simple measures of anxiety and depression each time they're seen, so that even if they were to finish treatment earlier than you might anticipate, you still have a clinical endpoint. And looking at the research literature, we thought if we implement the treatments really well, we should be able to get 50% of people to fully recover, and that's the red line on this graph, and about 2/3 to 70% showing really worthwhile improvement. As you can see, when we started the treatment, we were underperforming considerably. Many less people were recovering than we would have ideally thought from the research literature. And if we weren't collecting outcome data on everyone, we would still be in that position 15 years later. The clinicians would be blissfully ignorant, but around about 100,000 patients every year who we could get to recover wouldn't recover. But thankfully, because we collected data on everyone, we were able to explore differences between different services. Some services were already doing very well in the first year, some were not. We learned a lot from that and fed that learning back into the system. And that's why, as you can see, for the last 7 years, we've consistently met those sort of ambitious outcome targets. In a short talk, it's not possible to say all the things that we've learned, but just to say, it turns out training people well isn't enough, because we had the same training courses right at the start and we weren't getting our optimal outcomes. So it's also to do with the way you organize them in a service and the organizational features of these services, and also making sure you learn from that. So one issue that we're all concerned about is equality for different ethnic groups. We found early on in the program that we were getting considerably better outcomes for the white population than other ethnic minority groups, but that wasn't true everywhere. In some areas, they were doing very well for minority groups. So we learned what they were doing and fed that back into the system. And as of today, there is no difference in outcome whatsoever between our white population and our black population, or our Indian population, or our Chinese populations, which we're very proud of. Next slide, please. The great advantage, of course, of collecting outcome data is you can also look at what are the broader benefits of giving people psychological treatments by using data linkage. And we've been able to show recently that if you give people good psychological treatment, which is faithful to the models and gets good recovery rates, then we really significantly reduce other healthcare costs in terms of outpatient and inpatient admissions for physical health. Remarkably, recently it's been shown that those people are successfully treated in the services for their depression and anxiety, if you follow them up for the next 3 years, have significantly less adverse cardiovascular events, including heart attacks and strokes. And we're finding that we're getting more people moving into work. Next slide, please. So this model has attracted quite a lot of attention, and we have been working with other countries to help them develop their own version of IAPT. One I'd like to particularly highlight is Norway, and there you see their own manual for the service. And they have recently done a wonderful randomized controlled trial where people were randomized into the new service or to continuing primary care. Obviously, the clinical outcomes were much better in the new service, but what I'd like to draw your attention to is a further finding, which is that over the next 3 years, the people who were treated in the IAPT model had much higher income than those who were treated elsewhere. And that difference in income, the greater income, vastly exceeds the cost of delivering the service. So from an economic point of view, the benefit to cost ratio is large, about 3.6 for overall. But for those people who recover, it's massive, it's 9. Could I have the last slide, please? So this meant that yesterday, the Chancellor of the Exchequer in England, Jeremy Hunt, announced an extra funding for the NHS Talking Therapies programme of 1 billion Canadian dollars in order to further expand it because of the clear evidence that it helps the economy grow as well as helps patients recover. And the expansion is organized in a particular way where we're also being allowed to increase the average number of sessions to increase the proportion of people who fully recover, because the big economic benefits come from full recovery. So that's really me finished. Just to say that I hope it's been of interest to show how we train people to deliver the therapies and grow our workforce in an economic way, but also to emphasize that that's not enough. You have to really monitor the outcomes of everyone in the services, learn from that data, and focus very tightly on getting good outcomes for everyone, because that's where the big benefits to society arise. Thank you very much.
Thank you so much, Dr. Clark. So now we'll turn things over to our next speaker, Dr. Fonagy.
Thank you very much for that, and thank you very much for inviting me. I will try and follow David, but I have to say, I feel like but a child compared to David's extraordinary presentation. And really, I want to acknowledge that David has been an inspiration for me personally, but also for very, very many of us working in this area. So what I'd like to start with is a simple description of how things are in England at the moment for children and young people. Children and young people are important. I mean, you know, they are a quarter of the world's population. And the number one threat is mental ill health. About between 10 and 24 years, 45% of the burden of disease is associated with mental ill health. There is, on top of this, a kind of perfect storm that's brewing in children and young people's mental health, because it's a long-term condition. Birth rate is dropping, lifespan is expanding. it's these are the young people who are going to look after most middle-aged people in their old age. So them having mental health problems is a major, major issue. Also, probably childhood has become more complicated. Emerging adulthood take now longer. There are all kinds of destabilizing technologies that I'm not going to talk about. The extension of compulsory education has been a wonderful thing, but it's also caused problems of its own. And there's no question that young people have it tough. And not, we all know that they do. This Gallup survey of 60 countries that showed that when you ask people, do you feel that overall you have better or worse or roughly similar life than your parents, the vast majority feel that they are better off or the same. If you ask them, and do you think children today will have a better, worse, or roughly the same life to you, only 57% say better, same. So 43% actually see children's future worse than their own. So why is that? Well, the outcome of children and young people who experience mental health problems is very poor. The adult outcome, they have decreased life expectancy, they have emotional regulation difficulties, they have co-occurring disorders, mental disorders amongst them, as we shall see. But what I want to emphasize is that from everything that we know, intervening in childhood does reduce this risk. And we have done a couple of years ago a large-scale review study that was able to demonstrate some of that. What is happening to the prevalence of probable mental disorder in England at the moment? Well, between 2017 and 2023, there's been a 75% increase in prevalence among 6 to 16-year-olds. There has been, in 17 to 19-year-olds, 131% increase, which now probable prevalence stands at 23.3%, and that's about 32% amongst young women. But what's worse, that the trend is accelerating. So 10% increase in the 13 years between 2000 and up to 2017. But from 2017, in 6 years to 2023, that is 50%. I would also, not surprisingly, want to draw attention to the enormous increase in referrals. That is, this was associated with the children and young people's mental health services. So it's up to 60% increase, which is 138% increase in some areas like eating disorders. What's more, the presentations have been of greater acuity. So we have met this by an increase of about 31%, providing increased provision, but it is now at historic levels, and there's a widening gap between prevalence and what we're able to treat. And I will talk about that in a minute, but just to show that in order 17-year-olds, we had tried to increase, that's our target of increase of provision. We have undershot that. We're not doing so badly on 18 to 24-year-olds, but when you look at these bars, which correspond to the prevalence, and map that onto the provision, what you see is that the gap, notwithstanding increased provision, is widening, which is now about 27.3%, which means that probably over 70% of those with a problem prevalence of mental disorder are simply not being seen. This has led to, other than the gap, an overwhelmed service. So new referrals now number about 128,000 children in England a month, which is very, very large. It requires a significant and substantial change of the way we do things. And that's really what I want to talk about. So what do we need to do to tackle this gap, this massive waiting time? Well, we need to intervene in a way that therapies fit the need. They fit the clinical practice of practitioners, they work in non-clinical contexts, and they meet the need of the children and young people. They have to be goal-focused, and that is something that David drew our attention to, and is very much part of the improved access psychological therapy or NHS talking therapies model. But also, we have to target resources on early appearance of the problem, and that means on children. But the approaches have to be brief, they have to be low intensity, and they have to be cost-effective interventions in order to meet that very high bar that NHS talking therapies have set for us. And what we realized that in the NHS, we had insufficient brief and evidence-based interventions. And we needed to develop a low intensity workforce, low intensity intervention workforce that I would like to talk about. And child wellbeing practitioners and educational mental health practitioners are these new professionals that perhaps it'd be interesting for you to hear about. We have so far trained nearly 2,000 children wellbeing practitioners and 1,600 educational mental health practitioners. But this required a new conceptual frame. That came from Thrive, which is now in 3 versions that we have developed. I'm not going to talk about it for long, but it does now characterize about 70% as a frame of the NHS England clinical map. I would also say that it is now subject to the largest ever study of CAMHS and is reporting. So what is Thrive? It's dividing children and young people presenting for mental health services into 5 groups, into a group that is thriving, a group that needs advice, a group that should get help, a group that needs more help, a group that we cannot help very well, but nevertheless they need risk support. But for all of these, we need evidence-based intervention. So what is the input that's offered? Well, these are need-led approaches that are, I hope, characterized according to these 4 categories. In the first category, the advice category, it's signposting, self-management, and one-off contact. In the getting help categories, goal-focused, evidence-informed therapies, and more extensive treatment in the getting more help category, and risk management and crisis response in the final one. So what is the workforce that we need for this? Well, we've got different workforces for each of the categories, but I only have time to look at one of these. perhaps the most innovative. The children wellbeing practitioners and educational mental health practitioners offer low-intensity support in the getting advice, also in the getting help category, but in some context also for those who want to maintain mental health and well-being. So what do children wellbeing practitioners do? They help children with mild to moderate problem in their family by signposting, by goal-based input, but also maintaining current well-being. They improve outcomes through guided self-help, psychoeducation, and low-intensity cognitive behavior therapy. The specific interventions that they offer are assessment, but also risk assessment, behavioral activation, behavioral experiments, but intervene also with parents of children with behavioral problems. They have skills in lifestyle management and parent-led cognitive behavior therapy for anxiety. They have about 6 months training. They used to have 6 months training, but now they have a year's training and a more extensive repertoire of skills as well that goes along with it. But I want to, because time is short, I just want to briefly talk about something that I personally feel very proud of, but I know many others do. Moving mental health support teams into schools. Mental health provided in schools and colleges being the right help, the right time, in the right place. The interventions that we provide are evidence-based, one-to-one therapy, group therapy, parent classes, but also supporting whole school college approach interventions and giving advice to education settings, signposting to other services, supporting children and young people to stay in education, being outcome focused, as David emphasized, which is part of our training, being alert and to early indications of attentional problems, affect dysregulation, sleep disturbance, self-harm, and also substance abuse. The education of mental health practitioners is 1 year. It's postgraduate diploma on a national developed curriculum, exactly as David talked about as well. And there are in each mental health support teams about 4 EMHPs, and they are trained to deliver a range of evidence-based activities. They're trained also to work with different types of schools and colleges. The mental health support teams have a higher level therapist as well, who supervises and provides advice and some intervention on more complex cases. The schools have senior mental health leads who are experienced teachers, and they provide, if you like, a landing strip for the mental health support teams workers to help them meet the needs of children. And to end, the impact. So in our first evaluation, first of all, we now currently see about 74,000 children a month. So it's quite a few in these mental health support teams, not as many as David's services, but we now cover probably between 1/4 and 1/3 of schools, of the 25,000 schools in England. In phase 1 of our evaluation, the flexibility of the services, collaborative nature, the value of advice and support was emphasized, as well as the value of the direct interventions and the whole school interventions that were offered. Importantly, it also improved the confidence of staff to deal, education staff to deal with mental health problems. Workforce retention for us is a problem in the way that David mentioned as well, but they have dealt with perhaps better. Health inequalities may be a problem for us. David, again, a step ahead of us, has dealt with this. There is a gap between the mild and moderate problems that we can deal with and some of the problems that we encounter in schools, particularly in children who are autistic. Our longer term outcomes are being currently evaluated, and there is an audit that has just been reported on each mature site. There has been a wonderful growth of this service with currently 607 mental health support teams across England, who, to the extent that they report, and our reporting is nowhere near as good as David's, but an indication is that we have fairly high level of recovery of some measures, less well seen by the parents than by the children, that we have also feedback from children and young people that is quite positive, but I would say, and importantly, that over 70% of them report that they have achieved the goals that they have come with. And that is what I wanted to say. And thank you very much, Paul.
Great. Thank you so much, Dr. Fonagy. And thank you both to our first two speakers just for wonderful talks, inspiring the lessons that that we can learn from the work that you've done in the UK over many years, and just the value of transforming the system. Just before moving to the next speaker, I just wanted to reflect on just very two key, one image and one phrase, I think, that came out of your two talks that really resonated. First was the image of the Chancellor of the Exchequer proudly announcing a check for, I think it was 1 billion Canadian dollars. I think it just, the power of demonstrate outcomes and show the economic impact of this kind of work, how convincing that can be to our to governments. And then the phrase that really resonated with me, and there's so much to learn from both your talks, so I'm just picking and choosing, but the phrase that really resonated for me from Dr. Fonagy's talk was this, that the right help, right time, and the right place. So the power of delivering evidence-based interventions where children and youth are in the schools, and the immense potential of that. So thank you both. Much to learn again from your two talks. So I'd like to now shift now to our two Canadian speakers, and really looking forward to their talks. So we'll begin. Our next talk is from April Furlong.
Thank you, Dr. Arnold. I will start by sharing my screen. And is that visible to folks? Okay, great. First off, thank you so much for the opportunity. It's a privilege to join my esteemed colleagues today on this important topic. Just a quick bit of context, this project was commissioned by the Centre for Addiction and Mental Health with support from the Graham Beck Foundation in response to the fact that across Canada there is a shortage of skilled providers to support youth and adults with mental health and substance use health challenges. So the objectives of my brief presentation are to describe the approach for the scoping review that we'll be talking about, provide just a high-level snapshot of key findings and some examples of innovations that we identified, and just summarize the recommendations for the field coming out of this work. So the focus of our review was primarily on understanding and exploring the extent to which there's evidence and examples of work to redefine the kinds of roles that can support youth, and effective ways to attract, support, and integrate those roles into the workforce. The review also considered other strategies that have potential application in supporting work to redefine health human resource roles. And these include strategies to better leverage the traditional workforce to work more effectively and reach more people, and strategies to increase the size of the traditional HHR workforce. So our review had two components, an environmental scan of Canadian and international examples of innovative practices to redefine, leverage, and expand the workforce. And these were identified through an internet search. And we annotated 85 innovations, and we also conducted a search of Canadian and international literature. And our focus across both of these components was not limited to mental health services nor to youth. We wanted to learn from potential strategies used in other fields and for other populations to build their workforces. So these are the categories of innovations that we identified, and many of the innovations that fell under these had aspects belonging to more than one category. And so I'll just describe these by providing an example under each of these in the slides that follow. So beginning with structured interventions, we identified several for non-traditional roles in different sectors. And so the example provided here is from the HIV prevention field, which trained barbers and hairstylists serving African and Caribbean communities in Canada to offer basic information about prevention in culturally relevant ways. And a formal evaluation of this intervention found that it was in fact effective in increasing HIV knowledge amongst clients. It also increased their desire to protect themselves against HIV and overall was successful in reaching an underserved population. The next category is focused on capacity building, and we identified strategies aimed at attracting young people into a variety of roles, including non-traditional roles. And the example provided here is from the US, which was designed to give high school students the chance to graduate with a dual high school diploma and a certificate as a community health worker, which in the US are frontline public health workers that support licensed health professionals. And so this is one of several examples of innovations aimed at attracting people, and particularly people that we want to reach in our services, into supportive roles. The next category of a strategy is changes in scope of practice and task shifting. And the specific example here are our allied health assistants. So another important strategy is to expand the scope of existing roles or to create new roles that can take on tasks from other more specialized, more resource-intensive roles, like physicians, OTs, and social workers. So we found evidence that when these assistants are used in the allied health professions, they can be effective in improving patient outcomes, like getting people out of the hospital faster, and organizational outcomes, like saving money and resources. We also noted several innovations that leverage technology to expand the availability of support for people within different sectors. And so this example, MindEasy, is actually from the mental health field, and it uses artificial intelligence in an app platform to provide culturally sensitive prevention supports. And it was designed specifically for clients while they're waiting for services, which we, as we know, is an issue and is an important opportunity. And it's currently being used by over 200 people in any given month from around the world. Another category, we also noted several examples of innovations, many of which are aimed at knowledge translation and mobilization to build the capacity to influence the HHR workforce at a system level. And so this example from Canada is also specific to the mental health field, and it's focused on creating a national community of transdisciplinary research and clinicians to bring them together to disseminate information and build capacity to better serve youth and families. And this is inclusive of the potential ways that we could be leveraging non-traditional roles in the field as well. And then finally, we noted several innovations that shared characteristics with the others that I just described, but that have a primary focus on reaching, engaging, and building the capacity of people from health equity deserving populations to enter the health service roles. So this is another example of an innovation focused on high school students, this time from Queen's University in Canada. And this program is focused on Indigenous students specifically. And it provides culturally informed career counseling, education, resources, mentorship, and application support to succeed in post-secondary health professional training programs. And now I'll just end with some recommendations from our review. First and foremost, our review found lots of examples of innovations and evidence to recommend prioritizing work to redefine the mental health workforce, as well as the context in which these providers can support people. We found emerging evidence that non-traditional roles can effectively deliver services, and shifting less specialized activities and tasks can help maximize the use of more intensive resources. We also found evidence that non-traditional roles working in non-traditional spaces can also support more culturally responsive, relevant, and safe services, thereby potentially engaging more individuals from equity deserving populations. We also need to learn more about what works best, for whom, and in what context. While we found lots of examples of innovation, the amount and quality of research was generally limited. It's also important to give due consideration to the fact that introducing new and different roles or more roles into a workforce requires change. And we all know, or likely know, that change is notoriously difficult to introduce, to spread, and to maintain. So we noted in particular that there are especially important lessons to be learned from peer workers in the mental health field, particularly the importance of appropriate training, supervision, and professional development, the importance of defining and supporting core aspects of these roles, and using effective mechanisms to integrate them into interdisciplinary and team-based environments. Similarly, and as already discussed today, introducing new and different roles can only be effective if they can be retained and supported to work to their fullest potential. And so we recommend due attention to ensuring that workforce strategies are implemented, like equity, diversion, and inclusion policies, and again, learning from the experiences of integration of peer support workers in particular, and newly defined roles in other sectors. We also recommend exploring innovative ways to leverage technology, both for existing roles and newly defined roles. We found some really cool examples of innovative ways of using technology, including using robots to shift non-clinical tasks away from nurses, and using technology to expand the reach and impact of training and mentoring opportunities. We also recommend that any work to expand the health workforce should be done in partnership, including exploring opportunities to work with secondary and post-secondary educational institutions and other health systems. And finally, and above all, and overarching all, to prioritize a focus on health equity. So leverage innovations that develop roles drawn from health equity seeking populations and that builds their capacity. And all efforts, all of this work to redefine, expand, and leverage the workforce should be grounded in a health equity and a client and family engagement lens. Thank you very much.
Great. Thank you very much, April. So yeah, now I'd like to shift to our last speaker, also from Canada, and focusing on upskilling peer support workers. And our next speaker is Allison Dunning.
Hi, everybody. So I'm just going to take a sec to share my screen. You all know I cannot multitask, so just 1 second. Okay, you can see it?
Yeah, perfect.
Okay, perfect. Okay, so my name is Allison Dunning. My pronouns are she and her, and I'm the National Manager at Peer Support Canada. So I approached my work from the expertise that I've gained from having navigated the mental health and substance use health space systems as a white cisgendered female settler. And today, as mentioned, I'll be speaking about what innovation could look like in the context of peer support. So for those who don't know, peer support is a philosophy, a movement, and an approach to wellness, related care rooted in the belief that lived and living experience is expertise. So peer support involves someone who's gone through a certain experience, such as a mental health challenge or a stroke, supporting someone going through similar experiences with the emotional and practical pieces of the puzzle. So peer support involves a paradigm shift in the way that we approach care. So peer supporters believe that people they're supporting have within themselves the tools, knowledge, and expertise on their own recovery. And they approach the relationships with an emphasis on mutuality and empowering people who are coping with challenges to work towards the solutions that they think will work for them. In the Western world, peer support has been born out of the consumer survivor movement. So people who were abused and treated as though they had no knowledge or expertise to offer their own circumstances decided that they could offer the mental health and substance use health system something that was lacking. So they believed that there was power in the shared empathy, shared experience, and mutual respect and empowerment of peer support. So this philosophy became a movement towards increased respect for people coping with mental health challenges and a de-emphasis on top-down approaches to care. And this movement and this philosophy are sort of the basis of peer support service provision today. So now that we understand some of the foundations of what peer support is and how it came to be, I'm going to switch things up a little bit and talk about my own sort of foray into the field of peer support. So I grew up in Midtown Toronto. I had two parents who held good jobs. My dad was a teacher with the Toronto District School Board, and my mom was a manager with the Ministry of Transportation. I was a provincial level gymnast. I attended schools with good reputations. And both my parents keenly supported my school, my extracurriculars, and my social life. But I still really struggled a lot. My mental health took a really big nosedive when I was 16. And ever since then, I've coped with various mental health and substance use health challenges. So I've accessed mental health support through private care and hospital care, as well as counseling services throughout university. So I struggled my way through university, and when I finished my degree in psychology and sociology, I'd already faced many barriers related to my mental health. I started looking for work after I finished my undergrad, but of course, with just an undergrad, it was pretty tough to find anything in my field. And so I decided to start applying for volunteer work to sort of beef up my resume and increase my chances of getting a paid position. So I submitted an application to volunteer with the Mood Disorders Association of Ontario. I went through an interview process with them, and during the interview, they asked me if I was somebody that struggled with mental health. And I was very used to some of the reactions that I got when I admitted that, yes, in fact, I was somebody that struggled with their mental health. But when they asked me this, I sort of said, yeah, that's me, you know, that's what I come with. And their response was, oh, that's great. That's exactly what we're looking for. And at the time, that was a very innovative response to that question and that response. But that was in 2014. So eventually, through an effectively written email advocating for myself, I was offered a paid position with the Mood Disorders Association of Ontario, where I coordinated their peer support programming. So I helped with their peer support training program. I started supporting the development of peer support services in universities, community organizations, and hospitals. And as part of this position, I was offered the chance to apply for certification with Peer Support Canada. After 2 years of working with MDIO, I applied for a management level position with Stella's Place, where I oversaw a team of 7 peer support workers who were offering drop-in and registered peer support services to young adults in downtown Toronto. I continued to stay in touch with Peer Support Canada as a volunteer following my original certification. And so when a paid position opened up with Peer Support Canada, I stepped up to the plate and said that I'd be willing to help lead the organization in its next iteration. And that's where I am today. So I work as the national manager at Peer Support Canada, and I'm using my lived and living experiences to make sure that we're offering leadership to peer supporters and peer support organizations across Canada. In each of these positions that I held, I was taught some of the soft skills that help to lead a successful career, and people took the time to invest in teaching me the things that you need to understand in order to, write organizational policies, conduct program evaluations, manage budgets, and write grants. And I also have always understood the power of Google and have kept an open mind to learning new things along the way. So I've now been working in this field for almost a decade, so I feel like I'm in a pretty good position to identify what's innovative and what might not quite be innovative enough. And so in 2023, having people with lived and living experiences working within the healthcare system in frontline service provision roles is no longer innovative. To us, that's a given that people who have experienced challenges themselves can receive training and be equipped to be able to offer compassion, empathy, empowerment, and care to others who are coping with similar challenges. Don't get me wrong, I'm always happy to see peer support as part of any service offering, because we know that peer support is effective. We know that peer support brings an element of low barrier, culturally responsive, and trauma-informed care to the table that our system tends to lack. And I do believe that peer support services can be a demonstration of a step in the right direction towards real systems change. And I think it's important to reflect on where we may be falling short. So, the practice of asking people who have been harmed by a system to work within it and to ask them to be complicit to some of the practices and policies that originally caused them harm is not necessarily innovative. This concept is sometimes known as moral injury, and by hiring peer supporters into frontline positions without offering them the chance, the input, power, or voice to inflict change within these systems, we're running a risk of causing moral injury. So what would be innovative would be to dismantle some of the credentialism within our healthcare systems and to award the opportunity for traditionally marginalized populations with lived and living expertise to actually be able to inform some of the policies, funding structures, and practices that dictate the way that our healthcare institutions operate. What would be innovative would be to award people with lived and living experiences the same opportunities that are awarded to people with degrees and power that allow these people to move further into positions of power within our systems. So that would include things like benefits and paid time off, support staff, investments in ongoing peer support education, opportunities for non-precarious employment, and opportunities for those hallway talks that happen with people in positions of power, which all too often lead to the changes in the way that our government and systems work. Now, just to be clear, I'm not suggesting that individuals with clinical degrees and credentials and authority within our systems have not earned this. I wholeheartedly, personally, and professionally recognize the value in clinical approaches to care and the value that regulated professions offer to our systems. I'm simply suggesting that perhaps individuals who have lived and living experience of navigating these systems might also, and have also received training, work experience, might have the unique skills and competencies to be able to also inform some of these systems. Recently, I attended a conference in BC, and I heard a lot of people with, PhDs and clinical researchers, starting to talk about the value of client-centered care and putting the patient in the driver's seat, of collaborating with family and mutually developing care plans for people who are struggling. And I saw everybody at this conference sort of taking pictures and sort of sitting there riveted at the concepts that were being presented by people who are quite heavily compensated for their research. And meanwhile, in the back of my head, I was thinking about the fact that this knowledge has often been touted by people with lived and living experiences for quite some time, but we just haven't necessarily been listening to those voices because the lived experience perspective isn't necessarily always valued. Now I know what you're thinking, Allison, you're the national manager of an organization, you have benefits in your role, and you're invited to tables like this one to share your thoughts and ideas. And you use your lived experience within this role. This has got to be a good example of innovation in the field. And you're right, it is absolutely, I totally recognize that. It's a big deal that I'm leading a national organization and I don't have a master's degree myself. It's a big deal that people have trusted me in management level positions as I work from my lived and living experience perspective. And while I certainly have worked my butt off to be able to achieve the things that I've been able to achieve, the reality is that many of these opportunities have been awarded to me because of my privilege. So I was in a position where I could take on a volunteer role straight out of university because I had the financial support from my family to do that. I knew how to write a strongly worded advocacy letter speaking to my skills and aptitudes as a potential employee because my mom worked for the government and she taught me how to write a sassy and respectful email. And I was able to continue volunteering for Peer Support Canada while I was employed in other positions because I didn't need to work 3 jobs in order to cover the cost of my living, again, because of the support of my family. And that meant that I was sort of a known name when it came time to apply for the position here at Peer Support Canada. And then another reality about my own experiences is that while I have held these positions, I have often been paid the lowest paid manager compared to clinical managers that I work alongside. And a final reality about my own experience is that despite my achievements and my titles and my skills, I'm still not listened to as much as my clinical counterparts at times. When I'm involved in developing peer support programs within hospitals, or I'm an investigator on a research project, I'm often invited to the table by clinicians, and I'm not necessarily awarded the opportunity for me to set that table myself. And when I'm developing programming within traditionally clinical settings like hospitals, liability, risk, and regulations are often what is valued the most, and not necessarily the lived and living experience perspective. So again, what would be sort of innovative in 2023, 2024 would be if we actually genuinely, authentically valued lived and living experience as expertise. If we compensated people with this expertise equitably compared to the compensation offered for clinical expertise, and if we broke down some of the barriers that prevent this perspective from inflicting real change. It would be innovative to have people with lived and living experiences awarded the opportunity to reimagine a healthcare system in a way that was informed by these perspectives, rather than these decisions being made by privileged populations who often haven't experienced these systems in the way that the majority of Canadians do. So despite my qualms with this system as a whole, I'm truly grateful for the opportunity that I've been granted today. And I look forward to seeing other peer supporters in the driver's seat leading the next iteration of our healthcare systems. Thank you.
Great, thank you so much. Thank you very much to our last two speakers. April sort of began with really kind of a wide-ranging review of what's possible, not only within mental health, but also within health in general, in terms of different kinds of approaches, the ways in which we can think about broadening our perspective on the mental health workforce. And Alison, extremely thoughtful and reflection on your journey in peer support, as well as the potential and power of that model. And so thank you so much for that. So I, first of all, just wanted to mention that, again, we do have the opportunity for a Q&A. I'm going to start off with just a few reflections before we get to that, but just wanted to let you know, please don't be shy, pop some questions in the chat. We'd really like this to be, we do have a bit of time. And by the way, thank you to the speakers for being on time, because we actually have a good time for discussion. So please do let us know if you have questions, and we will respond to those. I just wanted to kind of begin with just a few reflections on what I've heard, and maybe picking up on some key themes, some of which I think will be obvious to you, and so I've mentioned as we've gone along, but just wanted to talk about just things that run throughout the talks. And I think the first key theme is really that idea, again, maybe something that's very central to this topic about the mental health workforce, about how we really have to be flexible and innovative in our thinking of who is a mental health professional, really thinking outside of the box. Perhaps like me, many of you have actually learned about new models, some of which I thought I was familiar with, and I actually learned some new models, some new approaches. So just to name a few that came through the various talks: psychological well-being practitioners, educational mental health practitioners, in the health field, allied health assistants, but that has obvious relevance for mental health as well. Of course, peer support workers. All of this kind of to that goal of really improving the effectiveness and efficiency of how we deliver mental health services at a range of intensities. And again, to borrow Dr. Fonagy's phrase about getting individuals with mental health concerns the right help at the right time in the right place. Related to this, what I've heard again throughout the talks, so not only about thinking in innovative ways about the workforce, but thinking about training. So all of these models do require training, and training in evidence-based approaches. But, again, as per Alison's talk about, this idea of credentialism, it doesn't mean that the training has to be a decade-long training. And there's still a place for that in our more traditional mental health professions. But there are effective models that involve relatively brief periods of training in a standardized way using standardized curricula, such as the one that's been introduced through the IAPT model. And in fact, in that model, what was really impressive is how it's been introduced at a very wide scale throughout the UK. So we can learn a lot from that. So just that sort of the thinking in innovative ways about the types of mental health professionals, about different models and the training that's required for those. A second theme that ran throughout many of the talks was just this idea of data, kicked off again by Dr. Clark's talk at how the power of collecting outcomes and that can help us both at the global level. So we can look at, that was so interesting and impressive to see that, Dr. Clark's, the IPT model, you weren't meeting those targets at the beginning, but you could show that progress to the targets that you'd set out at the beginning in terms of the global outcomes and how effective this approach was. But also at the individual level, the concept of measurement-based care. As clinicians, we tend to, there's a lot of literature suggesting we tend to underestimate how effective we are. We think we're doing a great job, but if we're not actually measuring our outcomes and using measurements in our care to inform what we're doing, we're just going to continue doing the same thing, and we may not be as effective as we think we are. So that power of data is very important, and again ran throughout the talks today. And then a third theme, and I think in some ways this is maybe a bit of a work in progress, but this sort of transition from how do we go from low intensity services to high intensity services. There are approaches that, and that is clearly the place to start, that reach the greatest number and can have an impact, or reach people early in the course of their mental health disorder. But how do we balance that with maybe individuals who need more high intensity service? And that's something that clearly IAPT, the IAPT model, the work that you were presenting, Dr. Fonagy, if you've been looking at that and taking that very seriously. But how do we continue to work on that balance? And then I think with all of this, if we think about all of this together, that image again of the Chancellor of the Exchequer and the potential economic benefits of this, and the reason I raise this is important. I think much of the audience here were motivated by improving the mental health of our patients, our clients, but when it comes to implementing these programs, speaking to policymakers, to governments, they of course have to look at the bottom line, look at what's feasible, and to be able to demonstrate that not only are these approaches effective and impactful for individual patients, individual clients, but they can also actually help. They basically end up improving our economy by making people, by enabling people to be participants in the workforce, and improving their qualities of life and reducing some of the negative impacts of mental health. Extremely important. And then just finally, a couple of points that were mentioned in a number of the talks, but might be something to think about, or perhaps in the Q&A, is how do we improve even further upon ensuring that these approaches achieve equity, that they're reaching groups that are traditionally underserviced by our mental health services. Again, it was really actually encouraging to hear from Dr. Clark's talk that they're beginning to reach those targets, that they're finding that they are actually reaching, a huge range of individuals within the population, regardless of their ethnicity, for example, something that we, typically we don't see in our mental health services where there are inequities. So that was encouraging to hear, and something that we need to obviously keep an eye on as we transform our systems and transform our mental health workforce. And then finally, and again, this wasn't a major focus of today, but I was sort of intrigued by, in particular with April's talk about what's the potential role of technology, delivering care virtually, providing the potential for AI in some contexts. What's the potential role for that? And again, something to think about. So I will pause there. I think we have some questions in the chat, so I did want to turn things over to our audience. And Marnie, maybe if you could help me with moderating some of those questions.
We've got sort of 2 questions so far, and just encourage anybody to use the chat if you've got other questions as well. The first one, and the speakers touched on it a little bit, but it's really about change management. You know, it's hard to transform systems. And so what are some of the learnings that can be shared through each of the speakers' presentations that kind of help think about what was created, the momentum or the tipping point that ended up with besides just the data, was there anything else that we could be learning from with respect to change management in Canada?
Thanks so much, Marnie. And I think I could invite any of the speakers, maybe Dr. Clark, if you had a response to that question.
Yes, and I suspect Peter will too. But I think one of the key things to the success of the Adult IAP program was not to try and transform the existing systems initially, because that just seemed an impossible job. But we had a situation where the vast majority of people with disabling anxiety and depression in the community didn't get any treatment. So we decided to add something on top of what we already have, but something that followed, you know, a very strong evidence-based model and collected outcome data, and we learned from it. And we encourage clinicians to opt into the revolution. So if they're interested in working that way, they would get a new job in these new services. And I think in retrospect, that was a really good thing to do, because it meant that we could show that these new models worked very well. They were manned by people who in general, you know, were up for the challenge of evidence-based treatment outcome monitoring and things. And subsequently, it's been easier to now take those ideas and start implanting them in our more traditional services. So we are at the beginning of a quite long journey, I think, but we are definitely on that journey now of transforming our general community mental health services to ensure more evidence-based treatment and outcome monitoring and things. And I think, you know, Peter described a wonderful achievement in these education mental health support teams in schools. And I suspect it's no accident that that was a completely new territory for him to go into with his very strong evidence-based system and well-trained people doing the low intensity. And you see it's really working well. But, you know, Peter should speak for himself.
Thank you very much, David. And that's a nice segue to you, Peter, if you could comment on this issue around change management in your work.
Yeah, well, I think the problem is that I saw what David has done, and it became obvious that the only way of changing things is devising new things. And he's just absolutely spot on. You know, incremental change in principle works when the foundations are solid. But if the foundation is actually problematic, as it was in children and young people's mental health services in Cairns, you know, I tried incremental change. David knows I tried incremental change, and he was very nice to me and very polite, and never said, "What on earth are you doing, Fonagy?" He never said that, but he could have done, because we tried and we really failed on incremental change. It's only when we designed a new system that worked in a different way by different parameters that we really were able to increase the number of children and young people being seen, which is really the aim. And if we can see 74,000 children a month, then we're getting close to the 128,000 that are getting referred. That's really what this is about.
Peter, I wanted to just go back to the two of your comments. Really interesting. I love that phrase, by the way, about opting into the revolution. You know, and you know, encouraging clinicians to do so. But is there a slight difference in what you're saying? In that, David, you had talked about that you initially began with not it wasn't feasible to transform the entire system. You felt you really needed to reform the system. And is there a contradiction between what Peter was saying about how he basically tried incremental change at first, but ended up essentially inventing a new system, which was, anchored in schools, for example? I know it's not only in schools, but is there a contradiction, or is it just wanted the two of you to just comment on that?
I'll let Peter comment first.
But I mean, I don't think basically what I saw David do over since the early noughties, he set up a new system that worked by a different set of rules and a very clearly defined set of priorities. I mean, the two driving outcomes and evidence base are the two organizing principles that built the system of IAPT, and it revolutionized psychological therapy delivery in the UK. And watching that, it became pretty obvious that just incrementally changing CAMHS, trying to make it more evidence-based than it wasn't going to be enough. You had to set up a system that functioned independently. And I learned it from David. That's all I can say. So if there's a contradiction between what the two of us are saying, then I didn't learn it well, is all I can say.
That's not what I meant to imply at all. But David, sorry, go back to you.
I mean, I would agree with Peter. I think we're saying a very similar thing, which is that in both the adults and the children, the thing that has been most successful is to create a new system which has certain quality standards. The therapists are all trained to deliver the treatments well and has good outcome monitoring, and is co-designed with users in the community as well. And I think the schools initiative is really great, and we've got something good going in both adults and children. And then what happens is that the existing services notice some of these features, they see that they're doing well, and they slowly change, picking up some of the principles. They strengthen some of their training of the therapists and the latest techniques. They start to be thinking, well, shouldn't we be doing some outcome monitoring as well? Could we learn from that? That's a slow process, but it's a process that wouldn't happen at all if they didn't have models to look to in both children and adults that are working well. And you can think maybe we should aspire to some features of them, even if it takes us a bit of time.
Yeah, thank you both for that. And any further comments on this issue around change management from either April or Alison?
I just wanted to highlight the importance of involving people with lived and living experience in system change initiatives. In other work that I've done, it's proven to be quite instrumental, and I should leave it to Alison to say that, but so important and should not be overlooked.
Great, thank you. Alison?
Yeah, I appreciate that. Yeah, I think, ask the service users who are using the service what works for them makes a lot of sense. So they can be the ones to lead the systems change when maybe other folks are not quite ready. The service users certainly are. And so I do think that deferring to service users works. And then the other thing that I would say, and we deal with sort of environment readiness a lot with peer support because it freaks people out a lot. This concept of having people with lived experience working in these institutions and stuff. So I would say just sadly, it is still very necessary to have some sort of internal champion who's willing to sort of fight the good fight, and somebody who's already integrated there and has influence in that environment to help sort of change the environment and help people along on that change process, which can be quite difficult. To help them remember that the peer supporters are not there to take everybody else's job.
Yeah, thank you. Thank you. That's an interesting last comment about that, because that's my understanding too from the introduction of peer support models. Sometimes that there can be a feeling of threat that this is something that's replacing, or just there's a resistance to change. But so thank you for commenting on that. Marnie, I think we have other questions in the chat.
There are. So I'm going to stay with the outcomes and data for a second before we move on to a little bit about sort of the peer support. There was one question about sort of broadening, what do we mean by outcomes and mental health outcomes or meaningful outcomes? Can we think more broadly around them? So I don't know if there's any responses to that. And also there tied to that was around sort of data. How do we make sure that we count our service providers appropriately and accurately? And then again, connected to that is credentialism. Speakers have sort of spoken to about sort of training, but there's a sense of entrenched credentialism within our system. So how do we shift that as well? So they're connected questions, a little bit distinct. So I'll let you determine how the answers can flow.
Yeah, thank you. Maybe we'll start with the broadening of outcomes. And again, I think there were certain there certainly was a number of outcomes described in the different presentations. Again, maybe Peter or David, maybe give you first chance to respond to that question.
So I think the approach that we've taken in IAPT is to say that you need a fairly broad assessment of outcomes, and so we look at what clinicians are often interested in, which is the measures of the symptoms of the particular conditions, whether it's an anxiety disorder or depression. We also measure very carefully, though, the extent to which your mental health difficulty interferes with your life in lots of different domains. And we also measure the impacts on your employment and your workplace. And we also have a sort of anonymous feedback from patients on their experience of the services and whether they feel they're understood and whether they feel they got the right help. And our view is that you need that broad range of measures. And those are what are taken, but you don't necessarily see that in all of the talks, because if you're talking to politicians and you want them to give you some money, it has to be simple. And so, in our case, it's a very arbitrary, but ours is the percentage of people who recover from their clinical anxiety and depression. So that's the measure that the politicians talk about. It's not the measures that we look at, though. We look much more broadly.
Great. Thank you for that, David. Peter, any follow-up on that?
No, I think I agree with what David said. With children, there are slightly moving targets, as Paul, you would know all too well. They kind of grow up, so you've got to change what you are interested in sometimes in intelligent ways. But there are good measures out there. We know how to evaluate services for children that are in some ways easier to judge than for adult services, but less easy to control because there are the parents as well. So.
Yeah. Part of the complexity is getting the data from multiple informants. Yes. In the case of children. Any adding?
Correlate poorly.
Yes. Yeah, that's a very good point. Yeah, often they see things very differently, as we know from them. April and Allison, did you have any follow-up in terms of the outcomes, Allison?
No, not necessarily. I think that's I think to be honest, like in peer support, we look at, as they're saying, like we don't just focus on symptom reduction. That is not a goal of peer support. The goals of peer support are, do you feel less? Do you feel like you're more capable of coping? Do you feel more empowered in taking control over your own recovery type of thing? So recovery-based outcomes as opposed to, and those are sort of self-defined by the service user, which makes it very, very difficult to sort of make the case for funding and stuff like that when some of the outcomes are not, lower than 8 on the depression scale is not what we look for, but valuable nonetheless. And we do it anyways, even though it's not always what people want to hear.
No, appreciate that. Yeah, different outcomes for different purposes. We're hearing about the need for the message to be simple but simple but impactful when dealing with policymakers. But different outcomes are also very valuable as well. Marty, do we have another? We have time for just a little bit more. For more questions.
There was a question. I want to come back to the credentialism, sort of about sort of the
Yes, sorry, I
discrepancy
forgot. It was a
about
two-part
what
question.
is
Thank you.
privileged, sort of, or what is not. And then I'll also tie into that is about, particularly in the peer support, caring for those people who have lived living experiences and offering their support. How do we make sure to care for their own well-being? And I would broaden that to say anybody within this field. How is that being considered, in the programs discussed?
Yeah. Maybe I'll ask for kind of a quick follow-up on the credentialism and Allison, you had raised that about this issue of credentialism. I don't, again, responses from and April, maybe I'll start. Any thoughts on that? You kind of looked at a range of different approaches for a mental health workforce. Any comment on this idea of credentialism?
I can say something about it from
oh yeah, please do.
The English perspective. And I think we recognized both in children and adults that the scale of the problem was far too high to rely on any one profession to be delivering the treatment. And certainly, we have a good group of clinical psychologists. Peter and I have both been responsible for running clinical psychology courses. But we realized if we thought, this type of initiative would have to rely on clinical psychologists, it would never happen. We'd never have that many people. And so I think we've tried to build a workforce based on a coalition of the willing. And we've taken people from a very wide range of different backgrounds. And the emphasis is really on competence, not on credentialism. It's not from where you come from, not your professional background that matters. But we do aim in the programs that Peter runs for the schools initiatives and we run for the adult ones to ensure that the people coming from a very wide range of backgrounds, and some of them with lived experience, still all acquire the sort of skills that are needed in order to help our patients get to where they want to get to with treatment.
Yeah, thank you, David. Any follow-ups from the other speakers?
Mostly just wanted to echo that and to share that in the research we reviewed specific to youth, it was quite similar that it's not a particular profession or competency, it's people skills and being able to engage and treat people with respect. And so I think that's hugely important. And I think the other thing to keep in mind is that there's so many people that just need to vent, just need to have support, just need to have somebody listen, and they'll get better. And so again, this is Allison's area, but I can't speak enough to the importance of better leveraging peer support in the system. It's so critical and important.
Yeah, and I think just making sure it's complementary, right? Like the point is not that peer support is going to take over what psychiatrists and clinicians are doing. The point is that peer support is going to complement it, right? And help make sure that those services actually land, right? Bring some compassion and some humanity and some empathy and some commiserating to those experiences of accessing, like DBT or whatever it is. So I think, yeah, just help to reinforce that we still need everything that currently exists, and that some of these services can help to make those ones even more effective than they already are by complementing them, not by, saying that they're terrible or they're awful or anything like that.
Great. Thank you, Allison. And Marnie, I apologize for there was another question that had come in and you had mentioned briefly, but.
It's okay, Paul. I think really what I'd like to sort of echo that's come across in all of the chats is just strong gratitude for the speakers, and the topic, the importance of this, and the sharing sort of wisdom and the ongoing learning. So I think that was just highlighted in all the chats. So I'll just turn it back to you.
Yeah, thank you so much. Picking up on that, I would also like to thank the speakers today. So David, Peter, April, and Allison. Both all like really inspiring talks with a lot of evidence and data for us to think about in terms of the mental health workforce. And I'm sure all of us in the audience have learned a lot from your presentations, and they complemented each other really nicely. So thank you for that. I'd like to thank the audience, just for showing up today and to taking the time out of your very busy schedules, because part of what we know, and part of the reason we have this talk, is we know that for many of you who work in the area of mental health, you are very busy people, and to take the time to learn from us and share, I think, was greatly appreciated. So thank you for that. And then I'd like to thank, of course, the Graham Beck Foundation for bringing us all together. So thank you so much, Ian, for the work that your foundation does. Thank you so much, Marnie, as well. Gohar for helping us organize behind the scenes. So really warm thank you for all the work that you've done, and to the foundation, actually, for Graham Beck Foundation, for actually working hard over many years to help transform our system of care here in Canada. So thank you. Ian, if you had any final words, I'm happy to turn things back to you.
Yeah, that's great, Paul. I don't have too much to say. Thank you very much. That was great webinar, and thanks very much to all the speakers and everyone who attended.
Great.